You know that feeling maybe your fingers are buzzing or your hand just aches? It's kind of hard to ignore. It's surprisingly common, those sensations. And today, we're going right to the heart of one really frequent cause, carpal tunnel syndrome.
Exactly. Carpal tunnel syndrome, CTS for short. It's something a lot of you will definitely come across, maybe personally, maybe in your clinical work.
Right.
And our goal, really, in this deep dive is to boil down the absolute essentials about CTS. We're using your revision notes as the core here to give you a super clear, efficient understanding.
Like a shortcut.
Pretty much, yeah. A shortcut to getting a good handle on the key aspects of this condition, especially for revision.
Brilliant. Okay, so we're going to break down what CTS actually is, how it can start, who tends to get it more often, how it messes with, the way your hand works, and really importantly, what else might be causing similar symptoms. You need to rule those out.
Crucial, yeah.
Yeah.
The differential.
Exactly. We'll also look at who it affects, how it presents, how it gets diagnosed, the management options, the general outlook.
Prognosis, yeah.
And, what happens if you just leave it. Plus, we'll throw in some memory aids, hopefully make things stick a bit better.
Sound good.
All right, let's dive in. What actually is carpal tunnel syndrome, fundamentally?
Okay, so at its core, CTS is all about the median nerve getting compressed, getting squeezed, basically.
Right.
And this happens specifically within that narrow passageway in your wrist, the carpal tunnel.
Okay.
And it's this pressure, this squeezing, that leads straight to those classic symptoms. The pain, the numbness, that pins and needles feeling.
Ugh, yeah.
Mostly in the thumb, index finger, and middle finger. It's a really common nerve problem in neuropathy. And in fact, it's the #1 cause of damage specifically to the median nerve.
Wow. Okay. So it's a physical squeeze on a major nerve right there. Now, this carpal tunnel, what's the actual structure? What are we looking at anatomically?
Right. So imagine the small bones at the base of your hand, the carpal bones. They form like the floor and the walls of this tunnel. And then stretched across the top, forming the roof, is this strong band of tissue, a ligament called the transverse carpal ligament.
Okay.
So it creates this pretty confined space. And through that space runs the median nerve, plus all the tendons to let you bend your fingers.
Got it. Bony bottom and sides, tough ligament roof. Makes sense it could get tight in there. So what usually causes this narrowing? What leads to the nerve getting squeezed?
Well, the main driver, like we said, is just less space in that tunnel. And a few things can trigger that. Repetitive hand and wrist movements are a big one.
Ah, like typing all day.
Exactly. Typing, assembly line work, things like that. Also, trauma, like if you fractured your wrist or conditions like arthritis, can actually change the shape or size of the tunnel.
Okay.
Then there are hormonal factors. Things like pregnancy or menopause can cause fluid retention, swelling in the tissues.
Oh.
And that includes the tissues surrounding the nerve in the tunnel. That hormonal link might explain why we see it more in women and why it pops up at certain times of life. Definitely something to ask about when taking a history.
That's a really key point about the hormones. What else can contribute to this narrowing?
Well, certain underlying medical conditions are definite risk factors. Diabetes, hypothyroidism, rheumatoid arthritis. These can all cause inflammation or changes in the tissues within the tunnel.
Right.
But it's also really important to say, in quite a few cases, maybe even a lot, we actually can't pin down a specific cause. We call that idiopathic CTS.
Okay, so sometimes it just happens.
Pretty much. Though genetics might play a role sometimes, and other individual medical issues can factor in too, often it's probably a mix of things.
A combination. Makes sense. So moving on from the causes, who is most likely to get carpal tunnel syndrome? What are the sort of key risk factors to keep in mind? Okay,
top of the list, as we mentioned, is those repetitive hand and wrist movements. That's a biggie. Using vibrating tools for long periods too. Think construction workers, mechanics. That's another major factor. Obesity also increases the risk.
Interesting.
And statistically, women are more likely to develop CTS than men. Getting older also increases the chances.
Okay.
And if it runs in your family, well, that suggests there might be some genetic link, a predisposition.
Ah.
And finally, circling back to those medical conditions, diabetes, rheumatoid arthritis, thyroid problems, having those definitely bumps up your risk.
So it really sounds like a mix of, how we use our hands, our general health, maybe our genes.
Exactly.
All influencing chances. Okay, let's dig into the mechanics a bit more. What's actually happening inside the wrist, biologically speaking, when CTS develops? The pathophysiology.
Right. So as that tunnel gets narrower, for whatever reason we've discussed, the median nerve inside gets compressed. It's not just a gentle squeeze. It kicks off a whole cascade of events. It triggers inflammation locally, swelling around the nerve itself.
Okay.
And if there's already increased fluid pressure in the tunnel, or maybe some slight structural abnormality in the wrist, that just makes it worse.
So the pressure builds up, and what does that constant pressure and inflammation actually do to the nerve?
Well, the ongoing compression really disrupts how the nerve works normally. It can actually reduce the blood flow to the nerve.
Oh, okay.
And nerves need a good blood supply to function properly, to send signals. So this impaired nerve function is what you ultimately feel is the symptoms, the pain, the numbness, the tingling.
Right.
The nerve is basically struggling to communicate because it's being squeezed and isn't getting enough food from the blood supply.
That makes total sense. Now, you mentioned those symptoms, pain, numbness, tingling, but they aren't only caused by carpal tunnel, are they?
No, absolutely not.
What other things could be causing similar feelings? This must be super important for getting the diagnosis right.
Totally crucial. You absolutely have to consider other conditions that can mimic CTS. So one group is other median nerve compression syndromes. Maybe the nerve is getting pinched somewhere else, like higher up the arm.
Okay.
Then there's cervical radiculopathy. That's a nerve issue starting in your neck. A pinched nerve there can send pain, numbness, weakness right down the arm and into the hand.
So it feels like it's in the hand, but the problem's in the neck.
Exactly. And you might get neck pain with it,
Yeah.
or weakness in different muscles than you'd typically see with CTS. Even things like shoulder bursitis inflammation in the shoulder can sometimes cause pain that travels down the arm.
Wow. Okay, so the source could be quite far from the wrist. What else should be on that differential list?
Let's see. Thoracic outlet syndrome, that's where nerves or blood vessels get squeezed between your collarbone and first rib. That can cause hand symptoms too.
Right.
In much rarer cases, something like a TIA, a transient ischemic attack, or mini stroke could cause sudden numbness or weakness.
Okay, less common though.
Much less common presentation, yeah.
Yeah.
And then general peripheral neuropathy, that's nerve damage, sort of more widespread in the body, that can definitely cause tingling and numbness in the hands as well.
That's a pretty wide range already. Anything else maybe more localized to distinguish from CTS?
Yeah, definitely. Local problems like tendinitis in the wrist or hand tendons, fibrositis, which is more like widespread muscle pain and tenderness. Even tennis elbow lateral epicondylitis can sometimes refer pain or odd sensations down the forearm and hand. And two specific ones to really remember for differentials are pronator syndrome and anterior interosseous syndrome.
Okay, tell me about those.
So pronator syndrome is also median nerve compression, but it happens up in the forearm muscles. The key difference is often pain in the forearm, maybe before the wrist symptoms, and often less of that classic nighttime pain. A memory tip: pronator, proximal pain.
Got it. Pronator, proximal.
And anterior interosseous syndrome, that's mainly a motor nerve issue, again in the forearm. It mostly affects your ability to pinch with your index finger and thumb, or make the OK sign. Less sensory stuff. So remember, anterior action of index middle.
Okay, anterior action. Those tips are useful. That's a really helpful breakdown of things that could look like CTS. So let's get a sense of scale. How common actually is carpal tunnel syndrome? What's the epidemiology look like?
Well, here in the UK, it's actually pretty common. Estimates vary, but probably affects somewhere around 5 to 10% of adults.
Wow, that's quite a lot.
It is. And while it affects both men and women, there's a definite higher incidence in women.
Right, we mentioned the hormonal links.
Exactly. And it's generally more common as people get older, so middle-aged and older adults. But importantly, younger people can get it, especially if they have those risk factors we talked about earlier.
Okay, so more common with age, more common in women, but can happen to younger people too. Now, how does it usually show up? What are the classic signs and symptoms a patient might come in with?
The absolute classic picture is that pain, numbness, tingling, sometimes described as burning, specifically in the median nerve area. Thumb, index, middle finger, and maybe the side of the ring finger closest to the thumb.
Okay.
Sometimes those feelings can even shoot at the forearm a bit. And a real hallmark, a key feature, is that the symptoms often get worse at night.
Waking people up.
Very often, yeah. Disrupting sleep is a very common complaint.
Okay, nighttime symptoms, big clue. What other things might you look for when examining someone?
Well, if it's been going on a while or it's more severe, you might start to see weakness in the hand muscles. People might complain their grip strength isn't what it used to be. They drop things more easily.
Ah, okay.
Then, on examination, you're looking for confirmation of that pins and needles feeling in the median nerve distribution. Patients often say shaking their hand makes it feel better, especially if it wakes them up at night. A good memory aid. Night shakes.
Night shakes. Got it.
You'd also test the strength of their thumb abduction. That's moving the thumb straight up, away from the palm. And in really long-standing cases, you might actually see muscle wasting, like a flattening or thinning of that fleshy muscle pad at the base of the thumb, the thenar eminence.
Okay, visible wasting. And what about those specific tests, the provocative ones, Tinnels and Phelan's?
Yep, standard clinical tests.
Yeah.
So Tinnel's sign involves gently tapping over the median nerve path at the wrist. If that reproduces the tingling down into the fingers, that's a positive. Tinnel's, memory tip, Tinnel's tap.
Tinnel's tap, easy enough.
And Phelan's sign is where you ask the patient to hold the backs of their hands together, pushing them so their wrists are fully flexed, kind of like a reverse prayer position.
Right.
They hold that for about 60 seconds. If doing that brings on or worsens their typical symptoms, that's a positive. Phelan's. Think. Phelan's prayer position. We'll reverse prayer.
Phelan's prayer position. Got it.
So yeah, usually the diagnosis comes together from that pattern. Intermittent symptoms, worse at night or with certain activities, maybe progressing to weakness or that thenar atrophy if it's not treated.
Okay, so a good history and exam go a long way. But how do you actually confirm it's CTS? What investigations nail the diagnosis?
The gold standard really are the nerve conduction studies, NCS, and electromyography, EMG.
Okay.
These are electrophysiological tests. NCS measures how fast electrical signals travel along the median nerve. If the signal slows down significantly as it crosses the wrist, that's strong evidence of compression there.
Right, it shows the blockage.
Exactly. And EMG looks at the electrical activity in the muscle supplied by the median nerve, which can show if the nerve damage is affecting muscle function. Basically seeing that slowing or prolongation of the motor and sensory signals across the wrist points right at CTS.
So those tests look directly at nerve function. What about imaging? Does that play a role?
It can do, yeah. Imaging like ultrasound or sometimes MRI can be used to actually look at the carpal tunnel structure.
What are you looking for?
You might be looking for thickening of the ligament, swelling around the nerve, or maybe something else taking up space in there, like a ganglion cyst, or checking for any bony issues from an old fracture.
Okay.
So while the nerve tests, the electrophysiology, are usually key for confirming the nerve compression, imaging can give extra information, especially if the picture isn't totally clear, or before considering surgery, or to rule out other structural things. So to recap the useful investigations, definitely NCSMG, or ENG, electroneurography is another term used, increasingly ultrasound, and sometimes MRI if needed.
Okay, that makes sense. So once you've got the diagnosis confirmed, how do you manage carpal tunnel syndrome? What are the options?
Management usually starts conservatively with the simpler things first. Wrist splinting is a big one, especially wearing a splint at night.
Why at night?
Because people often sleep with their wrist bent, which increases pressure. The splint keeps the wrist in a neutral position, taking pressure off the nerve. The memory tip here, splint at night, all right?
Splint at night, all right, okay.
It's also really important to advise people to try and modify or just avoid the activities that clearly make their symptoms worse.
That makes sense.
And for pain relief, simple things like over-the-counter anti-inflammatories, NSAIDs can help manage the pain and maybe some inflammation.
Right. What about more direct treatments like injections?
Yeah, corticosteroid injections directly into the carpal tunnel space are quite common. They can actually serve two purposes.
Oh.
Well, first, if the injection gives good, even temporary relief, it helps confirm the diagnosis. It suggests the problem really is in the carpal tunnel.
Ah, okay, diagnostic too.
Exactly. And therapeutically, the steroid reduces inflammation right around the nerve, which often provides pretty significant symptom relief. Studies show maybe around a 70% response rate after a month or so.
That sounds pretty good.
It can be, yeah. Some evidence suggests certain types, like methylprednisolone, might give longer benefit. It can definitely delay or sometimes even avoid the need for surgery, at least for a while, but the relief isn't always permanent.
Okay, so if splints, activity changes, and maybe injections aren't enough, what's next?
Then you start talking about surgery. Surgical release of that tight transverse carpal ligament is generally a very effective treatment when conservative stuff hasn't worked.
How does that work?
The surgeon basically cuts the ligament, which opens up the carpal tunnel, creating more space and immediately relieving the pressure on the median nerve.
Okay.
It can be done through a traditional open incision or using minimally invasive endoscopic techniques, keyhole surgery.
Is one better than the other?
Both are generally very successful in relieving symptoms. The endoscopic approach might allow people to get back to work a little bit faster sometimes, but both are good options. There are even newer ultra-minimally invasive techniques using ultrasound guidance now, too.
Interesting. And after the surgery, what's recovery like? Is there rehab involved?
Yeah, post-op rehab is important. It usually involves wearing some kind of wrist support or orthosis for a bit, doing specific exercises to get the movement and strength back in the wrist and hand. Maybe using cold therapy for swelling. Sometimes things like laser therapy or technique to desensitize the scar area are used too. Return to work varies, maybe around 12 days for light duties, maybe closer to 19 days for full duties, but it really depends on the person and their job.
Okay. Are there any other non-surgical things people might try?
Well, some studies suggest acupuncture might help some people with symptoms, maybe grip strength, even nerve function.
Really?
Yeah, some potential benefit there. And physiotherapy definitely has a role, things like specific wrist stretches, nerve gliding exercises.
Nerve gliding.
Yeah, specific movements designed to gently mobilize the nerve and help it move more freely. A little memory tip, glide to avoid the ride being surgery.
Glide to avoid the ride. Okay.
And strengthening exercises too. While the evidence for some specific exercises or mobilizations is still kind of building, therapeutic ultrasound is another thing that has shown some promise for providing relief compared to placebo.
Okay, so quite a few options there, from simple splints right up to surgery and rehab. What's the general outlook then for someone diagnosed with CTS? What's the prognosis typically like?
Generally, it's pretty good, especially if you catch it early and manage it properly.
That's encouraging.
Yeah, many people get significant improvement or even complete resolution just with those conservative treatments we talked about.
Right, the splints and activity changes.
Exactly. And for those who do end up needing surgery, the success rate is generally very high in terms of relieving the symptoms and improving hand function.
Good to know. Are there things that affect how well someone does long term?
Yeah, the long-term outlook can depend on how severe the nerve compression was and for how long it was going on before treatment started.
So catching it early matters.
Definitely. And also whether there are any underlying medical conditions like diabetes that might be contributing or make healing slower. In some milder cases, especially in younger people, symptoms might even resolve on their own within about 6 months or so. But yeah, overall prognosis really depends on the individual situation. It's quite different from, say, a bone fracture where you have a more predictable healing time of, 4 to 8 weeks usually with the right management.
Right. Much more variability with CTS. So early intervention seems key. What can actually happen if CTS isn't treated or if it becomes really severe? What are the potential complications?
Yeah, if it's left unmanaged or gets really bad, several complications can set in. Persistent chronic pain is one major issue. We mentioned the muscle atrophy, the wasting of that thenar eminence muscle at the base of the thumb. That can become permanent, leading to significant weakness and difficulty with tasks needing grip or dexterity. And the nerve itself can become permanently damaged. This means you could be left with constant numbness or tingling, lasting sensory problems, and also permanent motor deficits affecting fine motor control, coordination, just general hand function.
Permanent nerve damage sounds serious.
It is. That prolonged, severe compression can lead to irreversible changes in the nerve, which is why, again, getting that early diagnosis and starting appropriate treatment is just so critical. It's all about preventing those long-term, potentially irreversible problems.
Right. Unlike maybe fracture complications like poor healing or stiffness, which can often be managed if caught, nerve damage can be final.
Exactly. Timely management is key for both. But the potential for irreversible nerve damage with CTS really highlights the urgency.
Definitely underscores the importance of not ignoring those symptoms.
Well, this has been incredibly helpful, a really thorough deep dive into carpal tunnel syndrome, pulling straight from those revision notes. Yeah, hopefully. We've tried to cover all the key bases, the definition, causes, risks, the pathophysiology, those crucial differentials, who gets it, how it looks, how to investigate and manage it, the prognosis and what can go wrong. The aim was a clear, high-yield overview for your MSRA revision.
Absolutely achieved, I think. And for all of you listening and revising, if you want even more comprehensive support for your MSRA exams, definitely go check out passthemsra.com. And for loads of great free resources, don't forget freemsra.com. Really useful stuff on both sites.
Definitely worth a look.
So the final thought really is, recognize those early symptoms. Don't ignore that tingling or night pain, and seek proper advice and management. It's so important for keeping your hands working well and avoiding those long-term complications.